My name is Aaron Gerds. I'm the editor-in-chief of ASH Clinical News. Welcome to this month's From the Desk of. Well, our feature article for the month of May looks at bagging, and this has nothing to do with getting your groceries or baseball or anything like that. It actually has to do with how drugs are supplied from specialty pharmacies for patient use. I think we're mostly familiar with the traditional buy and bill, where a hospital or a clinic will buy drugs and have an inventory within their chemo pharmacy within their building to then administer specialty drugs to patients. But there is a growing use of something called brown bagging. And just like you would with your lunch, a drug would be shipped directly from the specialty pharmacy, external to that organization, shipped directly to the patient, and the patient would then bring the drug with them to the clinic to be administered to themselves. And the idea here is it will bring down costs. This is in contrast with white bagging, where the drug is sent from the specialty pharmacy external to the organization to the clinic or hospital where the patient will be getting the drug on the behalf of the patient themselves. And there's also clear bagging now, where the drug is sent from a specialty pharmacy to the clinic in which it will be administered, but that specialty pharmacy is within the organization prescribing the medication. And then now there is even something called gold bagging, which is considered the gold standard of all bagging, where the specialty pharmacy is housed within the same building at which the medication will be administered to the patient and is sent from that specialty pharmacy to the clinic room to be given for the patient. So somewhat kind of veering back towards somewhat of a traditional buy and bill model, but still changing the way that the drug is acquired and paid for. So we're going to try to delve deep into the whole bagging situation. What are the pros and cons? What are the things we need to watch out for as people who take care of patients with blood disorders? In our coverage of the literature, I would like to point out two really interesting articles on acute leukemia that we're covering. Now, there's the eternal debate of when to transplant patients in first remission with AML. I think most will agree that patients with really bad risk disease, we transplant those, and those with the most favorable disease, we don't transplant those. But still, even patients with favorable risk disease, it's not really favorable, it's just not bad. And a lot of those patients relapse, and ultimately relapse, and we can't get them in remission or get them to transplant. So there's certainly a population of patients with favorable risk disease that we should be considering transplantation in first remission. And a paper by Othman that was published in Blood really looks at MRD as a way to understand which patients with NPM1-mutated AML should be considered for transplant in first remission. In our literature scan section, there's an article by Dr. Short that was published in the Journal of Clinical Oncology looking at azacitidine, venetoclax, and gilteritinib. So is the era of triplet therapy for AML here? And there's a really nice perspective done by Dr. Curran to go along with that article. So along with this, we have our latest and greatest and society news and all the other normal features that we have within ASH Clinical News for the month of May. We're absolutely thrilled to bring you this edition of our magazine. And until next month, keep the blood pumping.